Good morning and happy Friday. I'm Danielle Lauder, Director of the Northeast Telehealth Resource Center, and on behalf of the Mid-Atlantic and Northeast TRC teams, I'm very pleased to welcome you to our first of 4 sessions in our virtual telehealth conference series. As you may know, the Northeast and Mid-Atlantic Telehealth Resource Centers, or NETRIC and MATRIC for short, are 2 of 12 resource centers funded by HRSA's Office for the Advancement of Telehealth under the Federal Office of Rural Health Policy. Collectively, the regional TRCs cover all 50 states, DC, and US territories in the Pacific Basin, providing technical assistance and resources to a wide variety of stakeholders looking to implement telehealth to improve access to quality care. We also work closely with our colleagues at the 2 national TRCs, the Center for Connected Health Policy, which has been very busy keeping us all up to date on the rapidly evolving telehealth policy landscape, and who will be sharing the latest updates on July 10, and the Telehealth Technology Assessment Center, who are our tech gurus providing expertise and unbiased guidance on the broad array of digital health solutions available out there. The TTAC team will be hosting a technology showcase on July 10 as well. The NETRIC and MATRIC have typically held in-person events each spring, and while we've all had to move away from many traditions over the past few months given the pandemic, the TRCs are used to working together, and we said, hey, we're telehealth resource centers, let's take this thing virtual for the East Coast. We'd certainly love to be seeing you all face to face and hope that we can do so next year at this time. However, going virtual means that we can offer you speakers from both regions, across the US, and even Canada. You'll see in the agenda that we've lined up a phenomenal group of keynotes, breakouts, and poster sessions, as well as multiple opportunities to engage with technology industry partners. We also hope you'll use the conference app to connect with presenters and other attendees. We can't wait to hear from today's keynote, but before we move on to that, I'd like to say many thanks to all of our presenters and moderators, our AV team, and our industry partners for being flexible with us as we dove headfirst into this virtual version of our annual events. And a huge shout out goes to the NETRIC and MATRIC teams, specifically Dr. Kathy Wibberly, Director of MATRIC, who you'll meet momentarily, Anita Browning, Outreach Specialist for MATRIC, and Reed Plimpton, Project Manager for NETRIC, whose Herculean efforts have made this conference series possible. And without further ado, Kathy, please take it away.
Good morning, all. I am Kathy Wibberly, Director of the Mid-Atlantic Telehealth Resource Center, and I have the pleasure of introducing Judd Hollander. And as most of you who have been at Matrix conferences, we do not do like the long bio read. So really quickly, Judd is Senior VP of Healthcare Delivery Innovation at Thomas Jefferson University, Associate Dean for Strategic Health Initiatives at Sidney Kimmel Medical College there. And he's got probably about 10 other hats, which I won't go into. But most of all, I think Judd is a good friend, a good colleague. He has been one of the people in our region that I have just really enjoyed working with. And I think characteristic of most ED docs. He is someone who is a straight shooter. He makes decisions and things happen. And so I am going to punt to Judd.
All right. Thank you, Kathy. It's actually truly an honor and pleasure to, I guess, be here, which we now define differently these days. So it's nice to not have to travel to get to speak to everybody. And I look forward to the comments at the end. So I was asked today to speak about scaling telemedicine in response to COVID. And so we'll talk about that. But I think there's a couple things to say up front that are critically important. Can we go to the next slide, please? Oops, go back to one slide. I think we skipped ahead. Okay, so I think that we talk about telehealth, and many of us that run telehealth programs spend a lot of time in the weeds. But I think it's critically important to just say these things up front. Telehealth is not about the technology. It's really about the workflows and operations. It's about how we can enable people to take care of patients. It's not actually about what platform we use. Telemedicine is just a care delivery model. It's healthcare. A lot of times I hear people talk about, oh, I got care via telemedicine. No, you didn't. You got care via your cardiologist or pulmonologist. You got content expertise that was just delivered to you via telemedicine. The medicine is the same as in-person or any other form of care. And getting to that, often people like to compare telemedicine to in-person visits. And I think that's the wrong comparison. The comparison is what you could have gotten otherwise. And what you could have gotten otherwise might be nothing. It might be because it's a snow day. It might be because there's COVID and the office is closed. So telemedicine, again, is just one of the tools we use to take care of people. I also hear not doing a physical exam, but you are doing a physical exam. You just need to learn the right way to do it and the right tools to use in telemedicine, which may be engaging a family member and having them help you. And I think it's also important to realize you might get more information than you get in an office visit because you're now seeing people in their home or wherever they are. You could look at the room behind me and tell it's not a mess. I was at least capable of cleaning it up for one day. That might be a critically important thing to know for a patient who's on rehab. And then particularly in the setting of COVID, it's critical that you don't, if you already have a program, you don't sacrifice your long-term strategy because the OIG or the feds relax some of the rules. We need to develop a durable, scalable long-term strategy for telemedicine. So with these overriding philosophies, I'll go to the next slide, please. So I was asked to talk about scaling, and I think scaling assumes that you have something to scale. And so my first point is telemedicine is great in a disaster, but if you don't have it when there's not a disaster and you don't have it when there's not a pandemic, you have nothing to scale. So for those of you that are doing telemedicine for the first time, it's a really, really different approach than we had at Jefferson, where we've had a longstanding telemedicine program and have done over 100,000 visits pre-COVID. Um, but these are the specific ways we scaled, and I'll talk more about them in detail. We integrated telemedicine into our testing workflows for patients that needed testing for COVID. We integrated it into a remote triage process so we could see people when they're coming to the emergency department before we have to be face to face with them potentially coughing and sneezing on us. And we did the same thing at our testing sites. We used telemedicine to prevent the devastating social isolation that happens for people who have COVID when they're alone in a hospital room and they can't see another face because family members may not be allowed in, and every person who does come in is fully masked and you can't know who they are. We used it for inpatient telemedicine. As you know, there still is a significant PPE shortage. And so one of the ways you can save PPE is by not having people who don't need to go in the room to see the patient go in the room. So we were able to leverage telemedicine to do that, even if you were standing outside the room. And then finally, we spent a lot of time talking about COVID, but maybe more important is talking about all the non-COVID patients as well. We wanted to make sure that all the people who were going to get medical care that now had canceled in-person appointments were able to receive the right cardiology, pulmonary, allergy, rheumatology expertise to keep their chronic disease from getting worse. Next slide, please. So I used to, before COVID, give talks. I would talk about myth busting, and largely it was the things that I thought we needed to get over in order to make telemedicine successful. And these were the 5 myths I always spoke about. Patients don't want it. It's not as good as an in-person visit. You can't examine the patient. It's too hard, and it's not reimbursed. I can now reduce this portion of the talk to 1 slide, and that's the next slide. So with respect to the patients don't want it, you now know many patients do. And you now know, as we're coming out of COVID in the Northeast, that many patients like telemedicine so much, they're not really that excited about going back to in-person visits. And I'll show you a little data on this. People used to argue it's not as good as an in-person visit, but I used to say, sure beats a phone call or sure beats no visit. We now know for many patients it's as good as an in-person visit. And everybody who didn't want to do telemedicine 90 days ago is now happy doing telemedicine. Nothing like an infectious disease pandemic to change your view on telemedicine. The theory that you can't examine the patient, you could, and I'm not saying you should bill it, but you could actually do a level 5 physical exam. And it is obviously intuitive that it sure beats no visit or a phone call. It's not reimbursed. It used to say yet. Right now, reimbursement is pretty good. We'll have to see where reimbursement settles out over the next little bit of time, but most of us remain hopeful that we've demonstrated its value and reimbursement will stick. And then it was never really too hard, and I don't really need to speak to this anymore. At our shop, it took us 4 years to do our 100,000th audio video synchronous visit. We now do that in 5 weeks. Everybody's learned it's not really too hard. Next slide, please. So this gives you an idea. You don't need to see what's on this slide, but when you're beginning a program, you need to describe and need to define a governance committee. And so this just gives you an idea at Jefferson that we have a governance structure that includes everybody from rev cycle to marketing to finance to the tech teams to the telehealth teams to now we have a physician work group, much like you would have a client work group to prioritize things. The details of the slide aren't important. What's important is that you get everybody in your enterprise around the table to grow out the program. And my biggest piece of advice for those of you just starting is I, as a telemedicine expert, are very unlikely to ever become a rev cycle expert or a compliance expert. So I need my experts in rev cycle, compliance, marketing, and every other component, legal, to actually come to the table and add telemedicine expertise to their general portfolio of expertise. It's not a one shop within telemedicine that's going to do everything. Just embed it within the institutional structures. Next slide, please. So this is our Jeff Connect program, and this is what existed before COVID. And I want to spend a minute talking about this. In the inner gray circle, if you go to 6 o'clock at baseline, patients are at the baseline. And the first thing that happens to a patient, and I'll talk about this in terms of potential COVID, is they get a little sick. So they might just have a cough. If they don't get better, maybe the cough gets worse. Maybe they get shortness of breath and they show up in the emergency department at 12 o'clock. Some people, about 25% across the country, will get admitted to the acute care setting. Almost all of our patients we put in the hospital get better and go home and go through a post-acute care phase, and they return to either a new or their original baseline. And so we had built out programs before COVID hit all around this circle. And the programs that you see here, if you look at 1 o'clock, we have a robust neurostroke network. Robert Rosenwasser began this a decade ago, is in 38 hospitals, so patients can get their stroke care as they want. We had this program called Virtual Rounds, which was when patients are in the hospital, they actually can just, when the physicians or the care team, really the whole care team is rounding on them, they could by video patch in their family, wherever their family is, to avoid the communication problems that classically happen. Then at about 4 o'clock, we had, from 4 to 7 o'clock, really, we had a post-discharge program, or I'm a little sick program, where over 1,000 providers in the health system, again, pre-COVID, were able to see patients and offer clinic appointments to do that. We had a remote monitoring program where we were able to see people predominantly with heart failure or COPD at home. We had an e-visit program, which was for asynchronous text-based communications back and forth for patients. And then really what we considered before COVID to be our flagship program was our direct-to-consumer on-demand program, where patients could access ER docs 24/7, 365. And what Jefferson did that was different, whether it was financially prudent or not, was we took our own ER docs when they're not working in the emergency department and had them field the Jeff Connect video calls, which we thought would be a great way for the ER docs, who are basically the person that could be in the ER, to determine whether or not you need the ER and how much could we do out of the ER. And we were actually able to very significantly drive down ER utilization using that program and increasing access. So we were available 24/7, 365. And then we were working on and had the program existing, but not as widespread as it does now, what we call the virtual emergency department, which was the Jeff Connect app on steroids, where we could also get lab tests or imaging and not have the patients have to go to the ED and circle back and close the loop. And missing from this slide at 12 o'clock is a program that we had initiated about a year and a half ago that we called ED teletriage or teleintake. And this program, when you came into the emergency department, again, before COVID hit, you would be seen remotely by a provider who would be covering 2 emergency departments. They would see, they would examine you, they would write your initial note, and they would write your orders, so that, as most of you know, if you go into the emergency department, you don't get in a room right away. You don't get seen by a doc right away. At least we could initiate your care, and we were able to significantly improve what we call our left without being seen rate and our time to provider, and get patients through the system faster. So that's the program we had before COVID. But we also had a lot of training programs before COVID that were important to leverage. Can we go to the next slide? And I will say that we have always been pretty dogged about keeping track of our metrics and knowing how we're doing. And we began a couple of years ago when National Quality Forum published this report in August of 2017, adopting their measure framework. And so all of the outcomes, and I will show you a bunch of outcomes of our programs, fit into these domains. We look at access to care, financial impact and cost, experience and effectiveness, and we measure them across all of our use cases. And I'll show you some data on that soon. Next slide. So we have training programs, some for inside our institution and some for external to our institution. With the number of providers that we were training, we had created mandatory and optional modules so that people understood the legal and regulatory compliance components of how to do telemedicine. And when you're onboarded into the institution, much like you would have to do bloodborne pathogens or safety components, you do your telemedicine components. And then we created a series of physical exam modules that were optional, but for new providers on telemedicine, they could learn to do a physical exam. And internally, they're put in the same website as the mandatory modules so people find them easily. Externally, they're a CME package. We have a telehealth facilitator program where we train people how to be staff within telemedicine. We have a pre-health professional fellowship program where we take volunteer pre-med students and let them interact with students in the virtual rounds program, interact with patients rather, in our virtual rounds program. We have med student electives, residence electives, a one-year fellowship for physicians that want to come do it. Like I said, we have CME programs. We actually have it's actually a center for digital health education. We have a telehealth boot camp and a personalized individually tailored instruction program that we've done a bunch, and we have a consulting service. So much of this is in person, but much of this is also web-based modules. So this existed and allowed us to scale up and train literally thousands of providers over a single weekend in March. Next slide. So this is just a sample of you go to the web and you click on the module you want to do. Next slide, please. So this is our response to COVID. I just walked you around this. We call it the Jeff Connect wheel, but and I'll tell you the programs we layered on, and then we'll go through a couple of them in more detail. First button, please. So we took our on-demand program and we made that scaled up, and we went about a 20-fold increase in 2 days from about 20 calls in a 24-hour period. I'm sorry, about 400 calls in a good week to close to 2,000 calls in a week. And on a day-to-day basis, we saw increases as high as 20-fold. And we leveraged that both for COVID and non-COVID patients. So our talking point at the beginning of this, when we didn't know a lot about COVID, and there's a lot still unknown, obviously, was that don't go to the ER unless you're sick. Don't go to the urgent care unless you're sick. In fact, don't go to your primary care provider unless you're really sick. Do telemedicine. We'll take care of you on telemedicine. So we did that for both the COVID and the non-COVID patients really successfully. Next button, please. Then we had COVID screening sites. We did the 10 cities like everybody else did, and we did drive up testing. But in some of our sites, we did that by appointments because we didn't want cars blocking off all of the Center City, Philadelphia lined up to do this. So we said, call telehealth first. We will do an assessment. And if you're just somebody who at that point needed home isolation for 14 days, stay out of work, we did that. If you needed to come to a testing center, we could schedule you for a concrete appointment. You could drive up in your car, get your testing, and then we would close the loop on the back end. Next button, please. We used this concept of forward triage, which is before you got to the ED, we might be seeing you on telehealth, but when you got there, we might see you in a tent outside and screen you. And then we had a COVID side to the ER and a non-COVID side to the ER. So we used remote triage outside the ED to send people to the right place inside the ED and limit exposures. Next slide. We have this entity that Medicare calls interprofessional collaboration that we never did before. It's basically a curbside consult, but now it's a formal curbside consult. So in the past, I might call my buddy and say, hey, what do you think of this? Do we need to tweak the seizure medications? Now, using this concept of interprofessional collaboration, we would actually put an order in our chart the consulting physician would review the chart, but never do a face-to-face visit with the patient, and be able to both write a consulting note and call me back or the provider that asked for the consultation and give us advice. And there's a note in the chart and it documents the interaction. And that's a wonderful way to do something when you have one or two infectious disease experts that need to cover a bunch of hospitals and you want to make sure that they can stay at work. It also allowed us, using all of this telemedicine and these interprofessional collaborations, to make use of our physicians who were on home quarantine so they could still be able to provide care provided they weren't sick. Next button. So our inpatient telemedicine program, I mentioned we took this virtual round programs and we created in a couple days the ability to have providers see patients in the hospital when providers were not in the patient's room. They might actually be on the same floor, but not need to go in the room to deliver the care needed. They might actually be at home if they were on quarantine. And we leveraged that same system so the patients could interact with their family using the same device we put in the room of every COVID positive patient and every patient under investigation. Next button. Family visits just talked about. Next button. And then finally, we had the robust scheduled visit program, which we leverage across all specialties for both the COVID and non-COVID patients, so they could keep up their specialty appointments while the outpatient offices were veritably closed down. And we actually stayed open through the whole thing, but had very few in-person visits coming in. Next, please. So talking about some of these things one by one in both pre and post COVID, these following the NQF measure framework give some idea of our metrics. In our direct to consumer on demand program, 24/7, 365, staffed by our Jefferson ER docs, we actually see many new patients. And when we've looked at this, as many as 40% of patients that come into the system are new to our system. And the great majority, over 80%, would have sought care somewhere else, and we're able to provide that care for them via telemedicine pre-COVID. We know we save about $100 per encounter, taking into account what patients would do before and after. A net promoter score and assessment of experience is phenomenal. Obviously, patients save time, but the most impressive statistic we have is we actually ask about 10 days later on the survey, how many not would recommend Jeff Connect, but how many have already recommended Jeff Connect. And those numbers top 80% some months. So you can't do much better than have people that have used the service telling their friends to use the service 80% of the time. And then we've measured effectiveness. One example of what we've done is we've looked at antibiotic stewardship for sinusitis to make sure we're adhering to the Choosing Wisely guidelines and not giving out antibiotics. And remember, our docs are the same docs that work in the ER and the urgent care center. And we found we did at least as well, if not better, on telemedicine than we do in those other sites, even though it's the same doctor. Patients believe they're getting their health complaint addressed as they hope more than 90% of the time. Most require no further care. 3/4 of them we could treat just on telehealth. And of the small percent, which is about 5% that we send to the emergency department, the great majority of those actually end up getting admitted or a procedure, suggesting we're really effective in keeping the people that don't need the ER out and the people we're sending to the ER needed. Next slide, please. Post-COVID, we talked about this. We leveraged this to keep people out of the ER. And we, like you, saw a dramatic reduction in ER and urgent care volumes. And at our peak, we had actually closed down 5 of our 7 urgent care centers because patients just weren't going there anymore. And we had a 50% decrease in ER volumes and a dramatic increase in telehealth volumes. So we were taking care of patients and we had moved them from in-person to remote care. We managed the testing sites, but we had challenges. And I think, if we're going to get a second wave of this, and some of you have not been, aggressively using telemedicine, be aware of what the challenges are. One is there's increased volume. So we employed more than our ER docs during this time, and we made use of primary care docs who had lower volume in their office. And we made use of specialists who were able to take care of the COVID patients algorithmically. And we actually had 31 GI docs and cardiologists volunteer to help us in one 24-hour period. So handling the increased volume turned out to be all about training. because we had the manpower, but we needed to train people. And then we continued to use quarantine physicians. And what we did not do is we did not use retired physicians. It turns out just onboarding retired physicians, getting them through the credentialing process and teaching them how to use the EMR, we found would be more distracting than helpful. And so although we had a lot of volunteers come out of the woodwork, we put them in other places rather than direct patient care. Training, we were on remote platforms, so we were able to do that. And then quality control and reviewing the charts were other hurdles that we needed to employ people to help make sure the system ran smoothly. Next slide. So this is an example of tele-intake, and if you could play the video, that would be great.
Hi, Mrs. Smith. I'm Dr. Joshi. I'm your triage doctor today. What brings you into our ER?
I have a fever. I'm a cancer patient who's currently going under chemotherapy.
Are you having any cold symptoms, such as cough, congestion, runny nose, or sore throat?
No.
How about any urinary symptoms?
None.
Joe, can you put the stethoscope on Miss Smith's back for me, please?
Of course, doctor.
Miss Smith, take a deep breath in and out through your mouth for me. Miss Smith, I'm going to order blood, urine, and an x-ray for you. And then you're going to go into the back of our ER where you'll see my colleague who will determine the best course of action for you. Do you have any questions for me?
No, I don't. Thank you for seeing me right away. This was really cool.
You're welcome. I hope you feel better soon.
Thank you.
So you can see we pretty much can do what we do when we normally see a patient, and the patient is seen on an average of 9 minutes after arrival, and then they move out of the room and their blood work, x-rays are cooking so that by the time they get into a room, results are back, making it a more efficient process. So anyway, that's one of the things we do. Move to the next slide. I'll show you some feedback on that. Obviously, access to care. If you're getting in there within 9 minutes, that's great. Financial impact. This is actually one of the telemedicine components that even in the pre-COVID unreimbursed days was a positive revenue thing for the hospital. Because if you have a 3 to 5% left without being seen rate in your emergency department, people effectively are showing up asking for care and you're letting them go home without the care. We can now provide the care. So that's a positive financial impact. The experience, patients, providers, executive leadership team love this because if you can make your ER more efficient and move patients through more efficiently, it's a huge satisfier. ERs, there's nobody who wakes up in the morning and says, I want to go to the ER today. That's a great experience. So if we can make that experience better, that's terrific. And then the effectiveness is terrific, reducing left without being seen rates and improving all the throughput times. Next slide. So we, during COVID, managed ED intake as we did before, but we managed the arrivals at the testing sites. We built out systems like this at our, what we call acute respiratory centers, which are non-emergency department tent sites for people with COVID symptoms. So we could keep them out of the ER if they were well enough. And we actually redirected people after a medical screening exam. If you came in with an orthopedic bony injury and we could send you to the orthopedist and keep you out of the ER where there was a high volume of COVID patients, we did that and we were able to leverage this system to do that. Next. Virtual rounds we talked about already. This is a real patient who gave us permission with a real care team. She moved out of the ICU 2 hours before this photo. She looks pretty healthy. Virtual rounds, I think when we measure effectiveness, I don't know that it's really going to be effective, but when we measure experience, it's outstanding. It's phenomenal for the patient and it's phenomenal for the family at home. And it's actually great for the care team. You guys on this, you have all heard patients and you have all probably been a patient or had a family member who's a patient who had no idea what was going on with their care. And I've had people in my family tell me they're getting surgery when they're not, and people telling me that they're going home tomorrow when they're not. And so being part of the rounds when the physician and care team is in the room just transmits information so we can be better prepared when we have our loved ones in the hospital or when we are in the hospital. Next. So what we did is we took that program and we leveraged our knowledge of that to grow out what we now call inpatient telemedicine. So like I mentioned before, we actually put a tablet, we used iPads, and put them in the rooms of every COVID positive patient and every patient under investigation, so that we could take care of people in the emergency department, the ICU, and hospital rooms, whether or not there was an expert on premises. And we set this up through a web-based platform. So whether I was a quarantined physician or whether I'm a consultation needed at any one of our 14 hospitals, I could log on and very simply, I'll show you on the next page, be in that patient room. It decreased the number of patients, well, and family members and providers who are exposed, and just was phenomenally useful. Next slide. Talked about where the iPads were distributed. We actually used Zoom for this. Next. This is basically a sample of the tip sheet. It's a web-based dashboard. You log in the middle on the left. You then have a panel where you select the hospital in the bottom on the left. At the top right, you then select the ward and the room and hit, have call. And at the end of the meeting, you leave. And it's that simple. It's an open chat into the patient room. So all you need to do is connect to the right patient. Wonderful system. Did that a couple thousand times in the first couple weeks. Next. Our scheduled appointment program, which I talked about, we had over 1,400 providers trained initially and 400 regularly doing it. And we've actually shown, with respect to access, a decreased case cancellation rate. So you, like us, probably have a 25 or 30% no-show cancellation rate after an appointment scheduled. We had that decreased to 14% with telemedicine pre-COVID. We believe there's probably positive financial impact, but we can't prove that pre-COVID because our reimbursement models were horrible. But just some staffing efficiencies and room turnovers may be useful. Our net promoter score, again, great, was 59 for the whole fiscal year. Patients obviously saved time, and again, nearly half of them had already recommended Jeff Connect at the time of the survey. With respect to effectiveness across a gazillion different specialties, 83% of patients said they received the same level of care as an in-person visit. Next slide. So we've studied this, and you could just see multiple areas. I'm not going to go through each of these studies. In primary care, internal medicine, pre-admission testing, in surgery, in urology, you name it, ENT, we did it, surgery again, and emergency medicine. And we built it into our emergency medicine training programs. And before COVID, it was already built into these programs. So when we wanted to have residents and students return to the clinic, we were able to have them do telemedicine and get some online training via the Telehealth Facilitator program and some instructions on how to do physical exam via those modules. And they are now back in the clinics doing telemedicine under the supervision of the docs. Next slide. This is our Department of Medicine. It shows you how rapidly we geared up telemedicine. The blue lines are inpatient office visits, in-person office visits, sorry, and it's about 1,000 a day in the first half of March. Mid-March is when Philadelphia sort of shut down, and those brown bars are telemedicine visits. And you can see how rapidly we transitioned, so we were able to maintain, it's actually more than half, it doesn't look it here, more than half of our visits and 90% of them on telemedicine. My favorite slide's the next one, though. And this is, we actually had, and we don't have them anymore, we don't need them anymore, but we had metrics within each department and division to train people to do telemedicine. And you could see pre-March, we were marching along at about 125 visits, 125 visits, 125 visits. And in March, boom, 6,000 visits from one of our groups in Jefferson, New Jersey. So unbelievably rapid growth here in telemedicine. Next slide. So on neurosurgery network, I spoke about, this is, one of the things we're seeing and across the country is stroke patients were less likely to come in and heart attack patients were less likely to come in to the ER. So people were sitting home, but we actually have a neurosurge network to take care of these people at like I said, 38 hospitals. The impact and cost depends on what you measure, but we leave 80% of people in their community hospital. It was 56% before this. So we're leaving people closer to home rather than bringing them down to Philly. And our effectiveness is great. We increased the rate of getting them a stroke specialist. We increased the rate of TPA administration, which is the clot-busting drug used to treat this, and we've shown patients have better outcomes 3 and 6 months later. Next slide. We actually, pre-COVID, actually created a mobile stroke unit, and I know some, but not many other sites in the US have this. This is an ambulance with a CAT scan within it, with a telemedicine console within it. So we go to the patient's home. They don't have to be exposed to anybody. They could get the safe care that they want while they were worried about COVID. Of course, now it's safe to come back to the hospitals, but somebody would get to them sooner, get their scan in the ambulance, and initiate TPA in the ambulance. Next slide. We actually have an ambulance program with a partnership with a company called Ambulance, which is a digitally enhanced transport company. And so these guys are great. These guys actually went as subcontract to FEMA, both in New York City and Philadelphia and other places around the country. And this was a group of medics and EMTs that would put on the PAPRs and the PPE and help out however needed. So it was nice to be able to be part of that and to be able to deploy them and do safe transports between our facilities. Next. And they would telemedicine enable people. And so I'm getting closer to the end. And I think I like to describe telemedicine, like I said at the beginning, that it's really just simply a care delivery mechanism. And I actually like this quote from legislative testimony, so I'll actually read it. Our obligation is to provide quality care. I think we can all agree that it does not matter whether the care is provided on the 3rd or 5th floor of a medical complex, is documented in Cerner or Epic platforms, is performed by a physician who's wearing contact lenses or glasses, or whether the patient lives nearby or far away. Similarly, it should not matter whether the care that was provided was rendered via telemedicine or in person. Quality care is quality care. At the time this was, read to the legislature, nobody believed this. I think right now everybody believes this after the COVID experience. So we will be able to move along much faster than we were before. Next. Another thing we did that's cool is benefit design. And I mentioned this, it's not really related to COVID, but it might actually be related to how we can maintain reimbursement post-COVID, so it's important. We actually are a large enterprise. We have 35,000 employees. We're self-insured. And so we decided what we would do is if you called Jeff Connect and saw the ER doc via telemedicine, and the ER doc said, I can't handle it via telemedicine, and sent you to either one of our urgent cares or one of our emergency departments, we would waive your copay, which could be as high as a couple $100. And so that way we encouraged use, and we were able to drive down costs. And through innovative programs like this, there's a couple other things too, we actually trimmed about 5% out of our healthcare expenditures for the year. So benefits design and having people get rewarded for calling telemedicine first is one way to drive care to telemedicine, and might actually be a way for us to design programs that payers find responsible and they want to pay for in the post-COVID era. Next. So we've talked about telemedicine. I made the point we shouldn't be too in the weeds, but I think the take-home point is really about these 3 things, and we haven't discussed them. It's actually about communication, trust, and cooperation. And at the beginning of COVID, we had to communicate, stay out of the ER, stay out of the urgent care, stay out of the primary care office, because we didn't know what it is, but we're still going to take care of you. So we're going to leverage this technology where you could still communicate with us, and we're able to build trust that we're not just running away because COVID's here. We are still going to take care of you. That trust then gets leveraged in Pennsylvania, where we are, beginning to reopen, and the offices now have a safe way of reopening, and we can get people to come back in safely. We now have trust of the community that they're willing to come back. But the cooperation in all this process is critical, because we needed to cooperate with the patients and their needs. We needed to cooperate with the providers and across departments. Like I said, 31 GI and cardiology colleagues offered to help us out because they saw the need to take care of the patients via the on-demand platform. And we also need cooperation, not just between humans, between people, but between man and machine. And that's where telemedicine becomes really critical. we can't just buy a preset platform and say, use it. We need to figure out what are the workflows, like I said on the first slide, that will allow us to enhance the care of our patients in the manner least disruptive to daily care for the providers. So if we communicate, if we trust each other, if we cooperate, then we really can deliver good care via telemedicine. Next slide. And so we like to think of this as the doctor in the medicine cabinet. It's simply the phone or any other technology. We do great with it. And I am happy to invite you up to the front of the auditorium and take some questions.
All right, great, Judd. For those of you who have not figured it out, there's a chat box with questions in your app. And so if you put those questions in, you can actually upvote questions that you like and want to see answered. And I will be moderating those questions. So Judd, we have a whole bunch in the chat box already. So the first question is, have you found that with easier access to urgent or emergent care, that there's been an increase in total urgent care ER encounters virtually and in person, or patients seeking care more liberally for better or worse?
No, so that's a great question. And I've actually done a decent amount of looking at that. So our ER and urgent care volumes are down and remain down. Our ER volumes have come back to about 75%. Our urgent care volumes have only in person come back to about 60%. And we've looked at our ambulatory office-based volumes, and we would see, so let's say we saw 100 patients, 100,000 patients in a time period. We actually would then see about 50,000 or 60,000, and we'd see about half of them via telemedicine. As our offices reopened, what we saw is our total volume of patients went back up. So we're now maybe 80% of the total number of patients we were seeing before, but our telemedicine volumes barely went down. So we were seeing, we're still seeing 80% of the people. We're seeing 80% of the maximal number we saw on telemedicine still 4 weeks after we opened up the offices, but our in-person office visits are rising. So I think we believe that we will continue to have a very, very robust telemedicine program that may be as much as 30 or 35% of ambulatory visits, and the rest will be seen during in-person visits. But we have no hint and no suggestion that we're going to have increased utilization, which is, of course, what the payers are most afraid of. So I think, patients are pretty smart. They know when they need care. They just saw whether they did or didn't need care for a 90-day period. And I think our experience is patients are getting care appropriately, but telemedicine is now a tool that they use. But it's not like, hey, I got nothing to do, so let me do a video chat with my doc right now.
All right, great. Thank you, Judd. How are you using remote patient monitoring with patients?
So multiple different ways. So in the heart failure program, we have scales, we may have pulse oxes, COPD. Again, it depends on, there's no one answer. It depends on the specific patient. So one of the remote patient monitoring programs we rolled out was taking people who had COVID, who were being released from the ER, and giving them a pulse oximeter so that they could go home. In one version of the program, it's a Bluetooth pulse oximeter, and we get the feedback into our transitions of care team. In another version, it's a pulse oximeter that patients need to enter the information, because obviously rolling this all out overnight in multiple divisions, multiple hospitals on multiple different EMRs, there was no one size fit all program. In another version, it's text message based. So it's just, how do you feel today? Do you feel good? Don't you feel good? And if they don't feel well, then we do a video visit with them. So we've integrated every technology we can based on what our baseline electronic medical record and capabilities were.
And do you actually have a loaner program for your devices or tablets?
So I am very proud to say, Kathy, and we haven't discussed this, that 2 days ago, we were one of the people that got one of the FCC grants. So we've been able to take tablets and devices, or now we will get tablets and devices and give them to the vulnerable communities and do that via a loaner program and be able to connect them. So we are having ongoing meetings to roll that out over the next couple of days.
Fantastic. And can you talk more about the Institute for Digital Health?
So the Institute for Digital Health is an unfolding entity. Right now, it is a series of certificate programs that you can get. And I will direct you to the website rather than say too much on this, because I don't want this to be an advertisement, but it's a series of certificate programs that are not designed to teach you to be a provider of digital health, but are designed to teach you how to run digital health programs or to integrate them into your organizations. And so it will actually grow up to be a master's program in digital health with very rigorous coursework. It's not like I'm going to go spend an hour and do this and figure this out. We do have those kinds of CME programs and other things separate through what we call the College of Health Professions. But actually, if you Google the Center for Digital Health, or you're interested in the physical exam modules, if you just do Jefferson Telehealth Physical Exam, you'll find stuff. The links were on the slides early on if you want them, or people can email me or DM me on Twitter, and I could send you more direct links to it.
Can you talk more about accessibility for the hard of hearing, English speaking, limited English proficiency, visual impairment, and digital literacy?
Well, so I wish I could talk more about all of those things, but one theme that I didn't say, which I hinted at with the governance, is just make digital health and telehealth like everything else. So what do you do when you come into the ER and you don't speak a language I speak? I have a translator service. So your telehealth platform should be able to connect you to a translator service. If it doesn't, we all use phones in the ER. You could use the same phone and call that patient, and it's kind of clunky, but you could use one of the translation services that your health system uses, and you're seeing the patient on video, but you're doing the translation over the telephone like you would do in the emergency department. So I think you have to, or we have to be smart and just say, how would I do this in the real world? And then how can I do it in telehealth? And you'll find the answer to most of the questions. And that's what we've done for our translating services. We pieced it together initially. We now have it built into our telehealth platform. We can just hit a button and bring in the translator service. But if you're just a new program and you're trying to do this on a not really professional telehealth platform, then just do it the way you would do it in your emergency department or your office-based practice.
So how have you handled patients without access to internet and or phones?
Well, so obviously, if you can't call me, I can't see you. There's a lot of discussion about the digital divide, and I don't want to minimize it. But I do want to say, I believe more people have smartphones than have healthcare insurance. And so telemedicine, and I was just working, my past life, I was a researcher, and I was just designing a research study with people that have a large data set yesterday. And so please don't steal this idea if you're a researcher on the phone, although maybe you should, because more data is the better. If you actually look at telehealth, there is the potential that it narrows the healthcare divide and it improves healthcare equity. Because if I call many large health systems and I want to make an appointment and I have no health insurance, and I say I'll pay by credit card, they're still not giving me the appointment. They will only give appointments to people that have health insurance. But if I use my telehealth platform that takes a credit card, of course you need to have a phone and a credit card, but you don't need to have health insurance. So it might actually narrow the gap. And I think there are a lot of the large telephone vendors and internet vendors are actually, giving away Wi-Fi connections and things for free, at least during COVID. So if you could find a phone or find someplace that's open that you can get on through shared resources, you have a chance. But unfortunately, telemedicine is just a care delivery mechanism. It's not going to totally solve the inequities, but I personally don't believe it's making them worse. I think it might actually narrow the gap a little.
Great. Does your group have experience with managing Crohn's and colitis?
Our GI docs do. Our GI docs do Crohn's and colitis telemedicine. Without violating my own HIPAA, I have a condition, a GI condition. I have ulcerative proctitis. I do a lot of my visits via telemedicine. When I have a flare, I might not want to do it via telemedicine. But if I happen to be, if Matrix was real and we were there in person and I'm down there and I have a flare, well, I'm going to want to do that by telemedicine. So, and then a lot of the chronic care stuff, all my chronic care stuff for my own healthcare, I do via telemedicine because I feel fine and it's a check-in and they're making sure I'm okay. So I think, so the answer is yes, our group does do that. And I don't want to oversell telemedicine. Telemedicine is a healthcare delivery mechanism. It's a tool. I don't need a stethoscope on every patient I see. I don't want to do telemedicine on every patient I see. So there are some patients that are right for it sometimes, and some patients that are right for something else sometimes.
So how do you get labs and imaging for virtual ED visits, and how do they compensate the ED provider on Jeff Connect?
So you can compensate the ED provider a variety of ways. We just pay you're on call for the hour. You're basically getting paid to be the ED provider that's there because you're seeing patients continually for the hour. Other programs may actually pay you just per click. You get X number of dollars for each patient that you see. That's not actually the way we do that. How do you get labs? We have this cool thing that shoots out through your phone. No, I'm just kidding. We order your labs through either the Jefferson Labs or LabCorp or Quest or one of the commercial labs, and then it gets fed back into our electronic medical record.
And similarly, do you provide teleradiology services for X-ray readings, et cetera?
So not as part of the Jeff Connect telemedicine program. Of course, all radiology is basically teleradiology. So we have access to a PAC system, and I can order the X-rays through any one of the providers that's integrated into the Jefferson medical record. They go there, get it, and then I could dial up and see the X-ray images and reinitiate contact with the patient and make recommendations.
How do you suggest a provider scale up when they're only using Google Duo?
Well, that's a harder question. I think that at the end of the day, it's my guess that a lot of these OIG and federal relaxation of guidelines aren't going to exist. And people are going to need to figure out what is the best telemedicine platform for them. Many of the electronic medical records can have telemedicine added on, but it's not inexpensive. So I think it depends on the size of the practice and what options are available to you. And I want to stay kind of brand neutral, but it's really doing a survey of what's out there. And maybe that's one of the things that get a little bit lost in a virtual meeting is that you can't walk around the room and see what platforms are there for you and the exhibitor group. But I think I would say talk to colleagues that have like practices and see what they're doing. And then don't be afraid to reach out to some of the large telemedicine vendors. They may not have platforms that are perfect for you, but they may have some scaled down platforms that are more affordable.
All right, great. Thank you, Judd. And I think you've already addressed the accessibility question. So that is everything that I see on the screen. So if we can flip over to the slide deck again. I want to just thank you, Judd, for spending this time with us. And I think you are open to having people kind of join you in this Zoom room that we are in currently in a few minutes to have a more one-on-one conversation for a few minutes, if that's okay. And so maybe I can ask Danielle to post the Zoom room into the chat box, the question chat box. So just to address a couple things that have come up. One is all of the slides that Judd presented are available in the platform. And so they are, if you are on your phone, you'll need to go outside of the chat box for questions and go into details and go down to the bottom. You can get the slides. If you are using your laptop or computer, you would just need to scroll down from what you're watching right now from the platform, and you'll see the slide deck there. You'll also see, as you're doing your scrolling looking for the deck, that you can find a place to do evaluation of this session. So we would very much encourage you to evaluate this session for us. We definitely want to, this is our first time doing a virtual meeting, and so certainly want to know how our presenters do, how the platform's working for you. And last but not least, we enjoy having you, and you'll have a little bit of a break before our next breakout session starts. There are a number of things that you can do during your break. On your app, we actually have done a Perspectives from Industry Partners interview series, and you can access that and see some of those things. This is not a sales pitch, but it's actually a time to talk with industry partners. So Judd ended up talking about, the different technologies and a place to kind of visit the virtual exhibit hall. Well, we also have a virtual exhibit hall coming up on the fourth of our sessions, but the videotaped perspectives from industry partners really gives you an idea of what industry is looking for when they want to establish a good relationship with you. And so definitely not a sales pitch, but more of an informational piece. And so that's available to you. We also would invite you to kind of glance at the posters that we have available, because we will be having poster sessions coming up, and you can't kind of scroll through the topics easily, but you can look at the posters themselves easily and then see which session you might want to attend.
Thanks so much, Dr. Hollander. That was excellent.